Very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, our guest speaker for the day is no other than Dr. Saji Kumar from Mayo Clinic, Rochester, USA, and he's going to lecture us on definition and management of high-risk myeloma. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Jensen & Jensen, Unipath, Lucian, and Nirvin Life Sciences, and very well managed by Perfect Square. I thank Team Jensen & Jensen, Unipath, Lucian, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker for the day, Dr. Saji Kumar from Mayo Clinic, Rochester, USA. All our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for sparing a Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 27th of July, 2025, from 11:30 a.m. Indian Standard Time and 7 a.m. Spanish Time, we have Dr. Maria Diaz Campello from Spain speaking to us on myelodysplastic syndrome and update. Let me introduce our discussions for the day, and they are displayed here in alphabetical order. I will pause for a while for you to have a look at all our discussions for the day. So these are our discussions for the day. Now it's a time to introduce our guest speaker for the day. We have no other than Dr. Saji Kumar from Mayo Clinic, Rochester, USA. He does not require any introduction, but it's my formal duty to introduce Dr. Saji Kumar. Dr. Saji Kumar, MD, is a consultant in the Division of Hematology and the Mark and Judy Mullins Professor of Hematological Malignancies at the Mayo Clinic in Rochester, Minnesota. He serves as chair of the myeloma, amyloidosis, and dysproteinemia disease group at the Mayo Clinic, as well as research chair for the Division of Hematology. He received his medical degree from AIIMS, New Delhi. His postdoctoral training included a residency in internal medicine at the same institute, followed by a residency in internal medicine and fellowship in hematology oncology at Mayo Clinic Graduate School of Medicine in Rochester, Minnesota. He then completed a Mayo Foundation Fellowship at the Dana-Farber Cancer Institute in Boston. His research centers on developing new drugs and the drug combinations for treating myeloma. He is a principal investigator of multiple phase 1, 2, and 3 clinical trials. Additionally, he studies the mechanisms behind disease progression from precursor conditions and disstratification of plasma cell disorders. His laboratory aims to understand the role of bone marrow microenvironment in the development and progression of myeloma. He serves as chair of the NCCN Multiple Myeloma Guidelines Panel. He is the president of the International Society of Amyloidosis and vice president of the International Myeloma Society. He is the current editor-in-chief of the Hematologist, the American Society of Hematology's official member newsletter. Today he's with us and is going to lecture us on definition and management of high-risk myeloma. Well, thank you so much. I stop over here. Over to you, sir.
Thank you, Amit. Let me go ahead and share my slides. Is that showing up okay?
Perfect, sir. In full screen mode, sir?
Just back here. Okay.
A little bit because it's very short.
Is it
Small size?
Size?
The size is very small.
I wonder if it's because of the wide screen.
No issues.
Do you want to display it?
That would be the previous one because this is very small.
Let's see. Let's see if I can do this again. Is that better?
Same thing. No issues. You can go ahead, sir. No issues.
Okay. All right. I think it's a wide screen, so that's probably why it's getting compressed.
No issues. Yeah, you can go ahead, sir.
Okay. All right. So good evening, everyone, and thank you, Amit. let me go ahead and maybe talk a little bit about the management of high-risk multiple myeloma, and then hopefully have some discussion right after that. So when you look at
Somebody from iPhone, can you please switch off your mic? Somebody from iPhone, can you please switch off your mic? Mr. Kalpish, if you can speak. Yeah, perfect. So please go ahead.
Sorry. So the way we treat myeloma, obviously, this is a mostly incurable malignancy, though that may be changing right now with all the modern therapies. We do the initial treatment that is often inclusive of an autologous stem cell transplant in patients who can tolerate it, and then patients might undergo multiple lines of therapy during the course of their disease. Now, what we do know that over the past 2 decades, the treatment of myeloma has changed significantly. We have many new therapies that are available and many new combinations that have led to significant improvement in the survival in patients with multiple myeloma. Here you can see the data from both the SEER national database as well as from the Mayo Clinic data, that the survival over these 5-year time periods between 2004 to 2018 shows continued improvement in survival. But what is also very clear is that when you look at patients with uh, high-risk multiple myeloma based on the FISH abnormalities, you can see that across the 3 time periods, even though the survival of both the groups have improved in the Mayo cohort, the gap between the standard risk patients and the high-risk patients still is quite evident. So the question is, what can we do about it? And how do we define or how do we predict the outcome in a given patient with multiple myeloma? Now, one thing that is very clear, and this is not necessarily unique to myeloma, but all cancers, is that the risk is something that is a continuum. You have obviously patients who might die, who might progress within the first 2 years of diagnosis, and there are people who might continue in response for up to 4 years from diagnosis. So depending upon the outcomes, again, we can look back and say somebody had high risk or ultra high risk myeloma. But the important thing is to be able to predict this upfront. Can we say that a given patient in front of you have a good outcome or a poor outcome? So the current paradigm is one where we can classify patients into low risk, intermediate risk, and high risk, and that determines or predicts the survival of patients with multiple myeloma. What we are looking for in the future is that can we actually treat these patients differently in order to change this paradigm to one like this, where the risk itself has no implications on the outcomes of patients with multiple myeloma. Are we able to do that today? Let's take a look at first what determines the outcomes in patients with multiple myeloma. Some of them are the plasma cell clone related. So clearly the genetic abnormalities in the malignant plasma cell is the most important determinant of outcome. Now, there are other characteristics of the disease that also can predict the outcome, like the serum LDH, presence of circulating plasma cells, presence of extramedullary disease, high rates of plasma cell proliferation, and some of which are host-related. Age, obviously we can't change it, but we could alter our treatment based on age. The performance status is a powerful determinant, as is the presence of comorbidity, since we are dealing with patients who are often older. And then there are finally factors that reflect the interaction between the host and the tumor, like the international staging system, which is albumin, which probably reflects to some extent the M spike size, but also the interaction of the tumor with the host, and also beta 2 microglobulin, which is probably a combination of the renal function and also the tumor load. There are immune parameters. We see immune suppression often in the context of multiple myeloma. And of course, there's renal function that can have a significant impact on the therapy and outcomes in these patients. So first, let's take a look at the genetic abnormalities in multiple myeloma. And what you can see is that there are some abnormalities that are often considered to be primary abnormalities in myeloma. And these often include trisomies of odd-numbered chromosomes and translocations involving the heavy chain IGH heavy chain locus on chromosome 14. And there are certain distinct sets of partner chromosomes that you always see. Now, either of these mechanisms can lead to either MYC dysregulation or cyclin dysregulation, depending upon whether it's predominantly the hyperdiploid characteristic or the translocations. But importantly, these patients can also, these tumor cells can continue to acquire new abnormalities as the disease evolves. And these are often, these are considered secondary abnormalities that consist of monosomies, deletions, amplifications, microRNA alterations, as well as about a dozen recurrent mutations, most commonly that of the RAS genes, KRAS and NRAS. So the chromosome 14 translocations always can lead to again, disruptions in the activation of many oncogenes. Now, let's take a look at the 414 translocation, and you can see that the disruption of the NSD2 can lead to, if there's a late disruption, that actually can lead to very poor prognosis versus if there's no disruption. So even within a particular cytogenetic abnormality like 414 abnormality, there can be significant heterogeneity in the outcome, depending upon where exactly the translocation happens. If you look at the chromosome 17 deletion, again, you can have either a monoallelic deletion with one of the chromosomes 17s losing the short arm. You can also have a biallelic deletion where both the arms are lost, or you can have a one deletion and mutation of the remaining allele. And you can see that if there is no 17p deletion, your outcomes are reasonable. But if you have 17p deletion or a TP53 mutation, the outcomes are worse. And if you have both, then you really tend to have poor outcomes. Now, when you look at the other abnormalities, for example, chromosome 1 abnormality, there have been multiple studies that have shown that these chromosome 1 abnormalities can have really poor outcomes. And here, and you can see that two different studies again demonstrating that if you, one study showing that the chromosome 1q gain is associated with poor outcome and maybe amplification even a little bit more, though the difference is not that very clear. But we also know that these abnormalities may not be independently prognostic, as we will talk about when we come to the new IMS IMWG risk stratification. Similarly, when you look at the deletion 1p, uh, people with monoallelic deletion 1p has a worse outcome, and if you have biallelic deletion as shown in the red line in the second curve, you can see the outcomes are even worse. So when we look at the how these genetic abnormalities have been incorporated in the risk stratification system, we can look at the revised ISS staging system. This was published almost 10 years ago and was the first to incorporate routinely the cytogenetic risk. And this, again, classified patients into three groups with very differing outcomes. The one of the disadvantages of the system was that nearly 2/3 of the patients were in stage 2. Subsequently, there have been two efforts trying to see if we can make this risk stratification a bit more granular, fully understanding that these abnormalities often tend to be cumulative. The more you have, the worse the outcome is. This was the study we did at Mayo, looking at the Mayo additive staging system, where we gave one score to each of these high-risk markers. And as you can see, the more the abnormalities you have, the worse your outcome is. And again, in this model, the elevated LDH, ISS stage 3, 17 abnormality, 1Q gain, and high-risk IGH translocations were included. However, chromosome 1p is not here, and deletion 17 or TP53 mutation is not here. RISS 2 is the second revision of the RISS staging system, took a very similar approach, and again gave multiple points to different high-risk factors, looking at the cumulative impact, and was able to classify patients into 4 different groups with very different survival outcomes. But what I think is going to be used more commonly going forward is the recent IMS IMWG consensus genomic high-risk stratification. And this was born out of an effort trying to see if we can develop a risk stratification system that is primarily genomic based. And here you can see that if you need to have at least two abnormalities, or if you have one abnormality, it's either a 17p deletion, or you have a biallelic deletion 1p, or you have a beta 2 microglobulin more than 5.5 with a normal renal function. Or you can have a combination of two abnormalities like monoallelic 1p and chromosome 1q, or a high risk IGH translocation along with either of these chromosome 1 abnormalities. Again, kind of solidifying those initial approaches, looking at the impact of two or more abnormalities that can be combined to give the better assessment of risk. So the IMS genomic high-risk classification classifies roughly about 20 to 25% of patients with myeloma into the high-risk classification. Important to note that we don't really have an intermediate stage here. We really classify them into high risk or not high risk. The reason for that is twofold. One, we know that many of those patients with singular high-risk abnormalities are doing much better with the treatments we use today, like the quadruplet regimens and the immunotherapies. And we also wanted to make sure that we define a group of patients where the outcomes are still poor, so that we can design clinical trials specifically focused on those patients in order to try and improve their outcomes. Now, we know that this is not a final classification by any chance for two reasons. One, there are other prognostic factors that are not included in this risk stratification system. And two, we know as therapies improve, I mean, some of these high-risk factors may cease to be high-risk factors going forward. We know that the presence of mutations, especially those involving the DNA repair genes, can have a significant independent prognostic value on top of all these different things we talked about, and can potentially be added on top of the high-risk classifications, as was done by Dr. Walker and his group in the study, again, highlighting the heterogeneity within the patients with multiple myeloma. We are all very familiar with the gene expression-based risk stratification. There are multiple different gene expression scores that have been developed over the years, including the CHEP70, the HOVONs, the Skyline Diagnostics risk stratification score, and all of these do group patients into two groups with very different survival outcomes. Now, one of the challenges with the gene expression has been the difficulty in implementing this in clinical practice, given that RNA is not stable, unlike DNA, where we can archive the sample or use archive samples to actually look at mutation abnormalities. Now, one other characteristic that has really evolved over the recent years, that is, again, has been recognized for a long time, but recent studies have highlighted the independent value of presence of circulating plasma cells. And the more the circulating plasma cells, even without reaching the diagnostic threshold of plasma cell leukemia, is associated with significantly poor outcome. And this likely reflects the disease biology, which probably is very similar to what we see with extramedullary disease, which also has been shown to have a significant poor prognostic impact in patients with relapsed and newly diagnosed myeloma. So I think both the extramedullary disease and the plasma cell leukemia probably reflect similar biology, in that these cells are now independent of the bone marrow microenvironment and is able to survive. The biological studies have shown that these extramedullary disease, whether it's EMD or plasma cell leukemia, often carry abnormalities beyond the high risk ones we talked about, like the 17p, but they often have high rates of RAS gene mutations and other mutation or genetic abnormalities. So as we can see, the whole the risk stratification myeloma is really a continuum with increasing numbers of risk factors contributing to worse and worse outcome among patients with multiple myeloma. So we know that if you just have hyperdiploidy 11, 14, your outcomes are pretty good. You're looking at survival of about 15 years plus. If you have high risk, which means one isolated abnormality, then whether it be, again, proliferation of isolated cytogenetic abnormalities, again, these are high risk, but if you have multiple, then you really have poor outcomes despite some of the cutting edge therapies. Now, we are all very familiar with and we just talked about what can be assessed at baseline at the time of diagnosis in order to predict outcomes. But that's not the end of the story for risk stratification, because this is a continuous dynamic process, and we need to continue to assess patients as they go on different therapies. And what we know is that the response to initial therapy is an important risk factor. The depth of response is an important risk factor, and the durability of response is also another important factor that determines long-term outcomes. So when you look at patients who don't respond to initial therapy, right, and these are thankfully much less common now that we are starting to use more quadruplets. But when we look at the triplet regimens, or even a small numbers of quadruplet, and this is a study we did at Mayo Clinic, we can see that those patients who don't achieve a partial response with the initial therapy, they tend to have a poor overall survival, irrespective of whatever else they may have access to subsequently. Similarly, we also know from multiple different studies and meta-analysis that patients, the deeper the response, the better patients do, particularly patients who get to be MRD negative to the -5 or -6, have excellent progression-free and overall survival, suggesting that, again, it's likely a combination of the biology and also the therapies that we employ for these patients. And then finally, the durability of response is important. We know that patients who relapse very early after the initial therapy often have outcomes that are very poor. And it doesn't matter whether you start off as high risk or standard risk. If you relapse early, your outcomes tend to be quite poor among in patients with newly diagnosed myeloma. And then finally, there are some of the host factors we talked about. On the left, you can see the impact of age. The older you are, the poorer you do. On the right-hand side, you can see the impact of the performance stage. And when you have a performance status of 0, 1, 2, 3, or 4, your outcomes are very different in terms of overall survival. And then finally, the frailty of these patients are also quite important. This is the data from, again, a large cohort of patients, and you can see that the patients with the severe frailty and moderate frailty tend to have much poorer overall survival compared to those non-frail patients. So knowing what are the risk factors that predict poor outcome amongst patients with myeloma, the question then is, can we do anything about it? Can we risk adapt it? Can we implement risk adapted therapy for patients with myeloma? So clearly we need to understand, and there should exist some degree of difference in terms of outcomes. And we already saw that high-risk disease is associated with poor outcomes. We need to understand the drivers of heterogeneity. Why do patients behave differently? And we know that the biology, this is biology is primarily responsible for this. And again, genetics and frailty plays a major role in this. And then we also need to have different interventions that differentially affect the outcome in order to neutralize the differences. So let's take a look at, what is, when we talk about precision medicine, right? What is precision medicine? One of them is obviously, when you do a one-size-fits-all medicine, which is what is commonly done in many of the cancers. And then we can do what we call probably more like a stratified medicine, which is what we do right now in myeloma, where we group these patients into, again, standard risk, intermediate risk, high risk, and give them different therapies, or try to give them different therapies in order to neutralize that impact of this risk stratification. But where we really want to get to eventually is a precision medicine, where we're looking at individual patient and saying, based on the disease characteristics, the host characteristics, we're going to decide we are going to use a particular therapy. We are not there yet, but we are moving towards that. But we can safely say that we are more in that middle ground, where we are looking at more of a stratified medicine approach. So the question is, how do we individualize the treatment? So first, let's take a look at stratified approaches, where we have a lot more data. And then we will take a look at the precision approaches, where we have more limited data. And when we look at the stratified approaches, based on the risk stratification we have, how can we adapt the therapy? Either we can use a specific treatment approach that is different for high risk versus standard risk. We can target a particular level of response, or else we can vary the duration of therapy based on the underlying risk. So one approach is to intensify the initial therapy, right? This was what was done, for example, in the Optimum trial that was done in UK, which really looked at quite a intense therapy. So these patients got a 5-drug induction therapy for 6 cycles, got a single transplant, then they got a 4-drug consolidation for 6 cycles, then 12 cycles of triplet, and then doublet till progression. So quite intense therapy. We don't have obviously long-term data on this trial, but when they compared this with patients getting older therapies, they saw that these patients with high-risk disease, including plasma cell leukemia, who got this intense approach, seem to be doing much better than what was known historically. There is data suggesting that two transplants might be beneficial in patients with high-risk cytogenetic abnormalities, especially those with 414 abnormalities and 17p. This is data from the European cohorts. Now, there are prospective trials which don't always demonstrate a value for tandem transplant. More recently, we saw the data from the MIDAS trial from the French group, where they looked at patients who are not in a MRD negative state after induction therapy, randomized to single versus tandem transplant, and there didn't seem to be a significant difference in the depth of response in that cohort. Again, suggesting that tandem transplant might be a thing of the past, and we might not be using it so much going forward. Now, this is another approach that has been taken by the French group, where they're giving a 4-drug induction therapy, single transplant, again, 4 more cycles of consolidation, a second transplant, and then maintenance for 2 years. Here you can see that these patients are very high response rate. 2/3 of the patients are MRD negative. So clearly demonstrating, at least in this cohort, that a very intense approach and intense um, maintenance therapy can improve the response depth. Now, another approach obviously is to use 2 drugs for maintenance after the consolidation instead of 1 drug. And this is again data from the Emory group showing that patients who got a bortezomib lenalidomide maintenance therapy appear to do much better compared to historical controls. But there's limited prospective trial data supporting the use of 2-drug maintenance. We do have data from the Forte trial, which used the carfilzomib lenalidomide maintenance versus len maintenance. And you can see here there's a benefit for 2 drugs even amongst patients with high-risk abnormalities like the ones we talked about. Now, at the time of relapse, one of the biggest challenges we have in particular is the development of extramedullary disease, plasma cell leukemia. And again, one of the challenges we have seen even with CAR T-cell therapies and bispecific antibodies used by itself is that even though they're good responses, these responses don't last very long. Recently, we presented the data with the combination of teclistamab and talquetamab in patients with extramedullary disease. And these are patients with true extramedullary disease, which is soft tissue disease independent of the bone. And you can see that in this study, we had an overall response rate of almost 80% in patients with who are getting tec plus tal. Again, you can see that when you compare to when you're using these bispecific antibodies one by one at a time, the response rate is only about half of that. And these responses appear to be quite durable in these patients with high-risk disease, with 2/3 of the patients free of progression at about a year from the start of tec plus tal. So clearly, these are approaches that we could potentially consider among patients with high-risk disease, especially at the time of relapse. Now, another approach is to try and see if we can get to, in addition to using a particular regimen for a particular high-risk group, the next approach is just try to get these patients into MRD negativity by one way or other, by intensifying therapy or different approaches. And this is again supported by not a lot of prospective trial data showing intensification of therapy improves outcome, but rather looking at retrospective data showing that in patients with high-risk disease, if you can get them to be MRD negative, their outcome seems to be almost as good as the standard risk patients. And we also have the data showing that sustained MRD negativity over a period of time is associated with almost a neutralization of the outcome. So you can see on the left-hand side, whether you have RASS 1, 2, or 3, if you are MRD negative, your outcomes are very similar compared to if you are MRD positive. And the third approach you can employ in these patients is to continue therapy until disease progression. And this has been done typically in the context of high-risk disease in the current practice. And this is just a meta-analysis from before all the new therapies came along, but nevertheless demonstrating that continuous therapy can be associated with a better outcome. And then, so some of it is based on the cytogenetic-based risk stratification, but we can also do this treatment adaptation based on the age and the performance status, as has been done for quite a while. And this is almost 15 years ago that Dr. Palumbo published this article showing how we can modify the doses of the medications available at that time in order to make it easy to use in patients who are frail. And this principle can be extrapolated to the regimens we use nowadays, like DRVD. We already saw that in the context of Perseus trial, newly diagnosed transplant eligible intense 4-drug regimen with transplant and 2-drug maintenance. Compare that with the Cepheus trial, where we use the same regimen but in a less intense fashion without transplant in an older patient population who was more frail, and achieving quite impressive results with the quadruplets. But where we, as I said before, where we want to be is to move beyond that stratified medicine to get to that precision medicine stage. Can we get there? I think we have some early data to say that maybe the way we might go with some of these patients. A very good example are those patients with 11-14 translocation, right? Even though it by itself is not high-risk disease, this again highlights the importance of, again, targeting a subgroup of patients based on cytogenetic abnormalities. We have, from the different studies, venetoclax, a BCL2 inhibitor, especially in combination with dexamethasone, can give rise to almost a 60% response rate in relapsed refractory patients who are 11-14 positive. We think a lot of it is because of the B cell-like features present in the 11-14 myeloma cells, which lead to, again, high expression of BCL2. Another potential target is the 414 translocation. We know this is a poor risk marker, and there's actually a drugs that are in clinical trial like the KTX 1001 that is looking at MMSET, which is again activated by the 414 translocation, and see if we can inhibit the MMSET and lead to again epigenetic changes that can lead to myeloma cell death. Now, another approach has been to, again, focusing on those high-risk abnormalities. Like, so if you look at the 17p deletion or the TP53 mutation, what often happens in those patients is, again, the MDM2 um, which plays an important role in the regulation of the TP53. Can be a potential target. And there are several molecules that are in clinical trials or in development that is looking at trying to inhibit this interaction or from MDM2 and, sorry, no, it enhances interaction between MDM2 and the p53 protein, leading to its degradation or inhibit, altering that interaction. So the other approach has been to look at mutations that are specifically associated with poor outcomes, right? So we have the RAS mutations, we have BRAF mutations. This is example of a patient with the BRAF mutation where the vemurafenib was used, and you can see the impressive response in the paraprotein and the size of the plasmacytoma. Trametinib, which is a MEK inhibitor, has been used in several studies, again, trying to target the KRAS and NRAS mutations that can be present in almost 50% of patients with relapsed disease. There's a trial called Burma trial, which tried to combine the BRAF inhibitor with a MEK inhibitor and showed that we can get a VGPR in about 50% of the patients, and nearly all patients can get some degree of response. We tried to do a trial called the MyDrug trial, which again stratified patients based on their underlying risk, underlying genetic abnormality, and then gave them different therapies based on these particular abnormalities. For example, if you have RAS mutations, they got cobimetinib, but fully realizing that these targeted therapies by itself cannot control the disease given the subclonal heterogeneity. So we combine these targeted agents like cobimetinib, inacetinib, abemaciclib, and erdafitinib with ixazomib Pomdex. So what we do see is that, why do myeloma patients behave like this, right? One of the reasons is because they continuously undergo clonal evolution, and this has been shown by multiple different elegant studies. And we have seen that once they get to be triple class refractory, their outcomes are poor, but who gets to be triple class refractory fast? Those are patients with high risk cytogenetics. So genetically or genomically unstable disease will continue to become more and more difficult to treat as they continue to acquire additional abnormalities. So I think, again, myeloma, even though we think about it as a single group of disease, again, this is a group of disorders. Even though morphology remains similar, there are significant heterogeneity, primarily driven by the genetic abnormalities seen in the myeloma cells. But on top of it, there can be multiple cause factors that can alter or modulate the heterogeneity even further. So individualization of therapy based on the underlying risk status, and also further modified by the host status, is going to be the way we can actually overcome high-risk disease in multiple myeloma. So with that, I'll stop and then open up for any discussions. Thank you.
Thank you so much, sir, for that wonderful talk, as always. Always good to listen to you, sir. A very good learning from you, sir. Thank you so much. And now I request all our discussants to please put the hand raise sign so that we can start our question answer session with Dr. Saji Kumar. Dr. Roshni Pandey, your question, please.
Good evening, sir. Thank you for that insightful talk. I wanted to know in smoldering myeloma, how do we decide treatment in high-risk patients based on the genomic analysis or the NGS?
Right. So right now, the smoldering myeloma risk stratification is primarily based on the IMWG 2020, the Mayo 2018 risk stratification system. And that's primarily clinical or laboratory features. So we're using the M spike, the free light chains, the bone marrow plasma cell percentage. Now you can add the FISH abnormalities to that, and that is how we use the IMWG score. And we know that is depending upon the number of abnormalities, including the FISH abnormalities, we can identify those patients at the highest risk of progression, and that is one way we can integrate that. But this will change, I think, over the next few years as we try to look at the genomic abnormalities in smoldering myeloma. And there's going to be a few publications coming out later this year showing that we can use many of those genomic mutation abnormalities to identify patients with more specificity as to who is going to progress. So right now, I would say clinically, we want to use the 20-20 staging system, identify the high risk, treat them with either daratumumab or lenalidomide based on the phase 3 trials, or watch them more closely if they don't want treatment. Future state, we will probably be going towards primarily a genomic model at some point in time, like what we did in myeloma.
The second question is, previously we used to give a limited maintenance. Now we are giving continuous maintenance. Are there any standard risk patients where we could do a limited maintenance?
Absolutely. I think increasingly what the data is showing is that for the standard risk patients, a continuous maintenance might not be required. The question is going to be, who are those people where we don't need continuous maintenance? The UK group looked at some landmark analysis and showed that maybe after beyond 3 years, you start seeing less and less benefit. Now we have obviously some limited data, retrospective primarily in nature, showing that patients who are MRD negative and in sustained MRD negativity for over a year, we could consider discontinuing therapy if they are standard risk. And there are prospective trials asking that question: if you give 2 years of maintenance and discontinue based on MRD negativity, is that appropriate? So right now in the clinical practice, what I do is in standard risk patients at 2 years, we have that discussion. If somebody is having side effects, then I would definitely look at the MRD status. And if they are negative, I would stop therapy. If the patient is tolerating treatment well, don't really want to go off treatment, then I may not even do an MRD testing. I would just keep them on therapy.
Any other question, Dr. Roshni, ma'am? Yeah. Yes, ma'am. Yeah. Yes, ma'am. Please go ahead.
If one gives doublet maintenance, can one limit the duration of maintenance?
No, that's a good question. I hope we can. I think the reason why we use the 2 drug instead of 1 drug in the high-risk population is that we can actually get more depth of response. Because when you look at the lenalidomide maintenance in the standard risk patients, you don't really get a lot more patients into MRD negativity. Whereas if you're using a 2-drug maintenance, as we have seen with the Perseus trial and also with the Forte trial, we continue to increase the depth of response, which is probably more important for the high-risk patients. So the question is, can we stop? I suspect at this point in time, I would not stop both. But I think that we can make a case for at least stopping one of the drugs, again, based on MRD status, but we don't really have much of data to support that yet.
And my last question is, in a resource-limited country like ours, if we give limited number of DARA doses, followed by the stem cell transplant in high risk, can we, omit the further DARA?
I think it's a very
which
reasonable question.
patients?
Yeah, we can reasonably do that based on what we have seen with the Cassiopeia trial subgroups, right? So maybe if you can give DARA during the injection therapy, the incremental impact of daratumumab in the maintenance setting may not be that high. So I would say this is a great scenario where if you have standard risk disease, you could potentially give a 4-drug induction therapy, transplant, and a single drug maintenance with lenalidomide. And if you have high-risk disease, I would do, again, 4-drug induction, transplant, and then give them a 2-drug maintenance with bortezomib and lenalidomide. That way, the cost of care can be significantly reduced.
Thank you so much, sir.
Thank you, ma'am. Dr. Mukul Agarwal, your question, please.
Hi, good evening, Dr. Shaji. Excellent talk throughout. So, my question is regarding, let's like ma'am said about resource constraint setting. So, for most of our patient, we are using VRD kind of a regime for induction and subsequently len-based or bot-len-based maintenance therapy. Transplant is done for a significant proportion, but yes, it's not done for the majority of the cases. In such a scenario, how do you suggest we use MRD for our setting? Many a times it is not available or not standardized at many places. So should we be sending MRD for such patients and taking decision on its basis?
Yeah, so I think, I think some general principle, I think do the MRD only if you can act upon the results, right? So I think that's the key thing. So if you are looking at let's say, a high-risk patient, and so you look at each scenario separately, right? So in the standard risk patients, if the current paradigm is a single drug maintenance given continuously, then the use of the MRD testing there would probably be to support discontinuation of maintenance if you prefer to do that. And if in the high-risk patients, MRD could be used for intensifying therapy. So you can do the MRD testing at, say, 1 year from start of therapy, and the high-risk patient is still MRD positive. Then the question comes up, do we try to intensify or consolidate even further? But again, I think the other point that you raised, which is a standardization, is very important. So one of the things to think about is, how do we selectively use the MRD testing? So for example, you could argue that if the person is still is not in a immunofixation negative state, don't do the MRD testing until they become immunofixation negative, because your chances of that test being useful is more if they're immunofixation negative. And this will change in the future to a mass spectrometry based testing once it becomes more available. If you're not mass spec negative, you probably don't want to be doing the bone marrow yet. So trying to do the bone marrow when it's likely to be most informative, doing it in a clinical situation where it's most informative, is probably the best, most cost-effective strategy. In terms of standardization, that's a challenge, because the flow-based approach, the Euroflow, has very clear standardization processes that have been put in place. So if the labs can follow the Euroflow approach, then I think we clearly can make sure that these tests are done appropriately. So I don't have a good answer to that question about standardization. I think you just have to go with the lab that you believe in.
And the second question is about, some of the myeloma patient, they go into a MGUS-like state after achieving their best possible responses. So for such a patient, what is the importance of doing MRD testing?
That's a good point. And I think that's why I think, in the standard risk patients particularly, I don't routinely do that. And you see that more often in the standard risk patients. You don't see that often in the high risk patients, that phenomenon. So, and what happens is, obviously, I think we have converted them back into more of a MUGUS type stage. And this has been shown even with some of the studies from the Spanish group showing a MUGUS type phenotype on the flow cytometry is associated with better outcome. So I think that is the biggest challenge for us to routinely say we should do an MRD guided therapy for intensification. I think the MRD guided intensification should be limited to the high risk patients at this point in time. So I think what we have to do is, again, so the scenario where it would be a challenge is, right? So you have your patient who is still, who might be kind of MUGUS type patient, 2 years on maintenance. Obviously, the MRD is positive, but can we stop treating the maintenance? It's hard right now. We don't have a validated system to say that this particular patient is MUGUS type and this particular patient is not a MUGUS type, because a lot of them are research use only studies, and we don't really have a validated test that we can use in the clinic to say that residual disease is more like Muggles or more like myeloma. There are some tangential things you can do. You can look at, again, flow-based approaches, right? The flow morphology can sometimes help you with that. The flow can also help you look at the proliferation. But we have seen is if the residual myeloma cells have very low proliferation rate, these are patients who are very unlikely to progress right away.
And just a follow up on this Magus approach. So, the best of treatments are able to come to this stage, but why not eradicate this clone, let's say with database or something, just continuing with? Why doesn't it go away?
Well, the thing is, even when you're looking at, like the Perseus trial, that's probably one of the best examples of very high rates of deep MRD negativity. Almost, half of the patients are getting 10 to the power of -6. But still, many of those patients, I mean, they are still relapsing, though much lower than what we have seen in the past. So I would say, you know, uh, there is, I would say, the increasing proportion of patients, we are probably eradicating these. I think we're going to see higher and higher cure fractions with the therapies, particularly with the immunotherapies in the future, like what we saw with the cilta-cel, with the data presented at ASCO. But the majority of the patients, we still have residual cells that are somehow protected from the treatments, maybe because of the microenvironment protecting them and then subsequently relapsing. But that's a challenge that we have to sort out for future.
So, thank you very much. Thank you.
Thank you, Dr. Mukul. So there are some questions from the audience. Says one question related to 1Q gain and 1Q amplification. Do you go for upfront 4-drug therapy for those patients who are 1Q gain or with 1Q amplification?
Yeah, so for all practical purposes, I think, again, 1Q gain and 1Q amplification by itself is no longer considered to be, among the highest risk group. You need to have that along with another abnormality. Even though, there is some subtle difference between gain versus amplification, the fact that once you add either of those to the another high risk marker, it's pretty similar in terms of the outcomes. But going back to the question of would we use a quadruplet regimen, I think the current practice is use quadruplets for everyone. But in a scenario where you are not using quadruplets routinely for everyone, I would definitely consider that for the high-risk patients and use the triplet for the standard risk.
So is it okay, sir, that we can go for triplet also for 1Q gain and 1Q amplification? If the patient is
Yeah,
not...
I mean, the preference would be a quadruplet, but can we use a triplet? Yes. I mean, if you cannot use the quadruplet, then I would definitely at least use a triplet in these patients. But what one could do is, if you want to look at it again in a more resource stratified approach, is to give a triplet, and if you don't get a good response after the first couple of cycles, or for first 4 cycles, consider adding on the quadruplets. That's another way of the fourth drug.
Thank you, sir. Another question is from Dr. Yimon Tent. Would you prefer upfront transplant to IgA myeloma with standard risk cytogenetics?
Yeah, with IgA, with the standard risk cytogenetics, the outcomes are not that different from IgG. A lot of the difference between IgA and IgG is because of the higher prevalence of some of the high-risk translocations in the IgA patient population.
Thank you, sir. Another question he has is, any role of tandem autologous stem cell tandem transplant, that is autologous followed by allogeneic stem cell transplant for multiple myeloma with extramedullary plasmacytoma?
It's a good question. I don't know if it's necessarily, I think there's a significant role left for allogeneic transplant in myeloma. Very, very uncommonly do we use that, and mostly in very young patients with multiple high-risk abnormalities or very early relapse after initial therapy, we may consider an allogeneic transplant because the current treatments just don't keep them going for that long. Now, extramedullary disease per se, I would not use an allogeneic transplant because one of the biggest way, or one of the most common ways patients relapse after allogeneic transplant is with extramedullary disease. So I think there's limited kind of efficacy of allogeneic transplant for the extramedullary disease. So some of the new immunotherapies, like what we showed with the TEC plus tau, might be another approach for patients with extramedullary disease in the relapse setting.
Thank you, sir. So I think, yeah, there are no more questions from the audience. Yeah, any discussion want to ask any other question? Well, so that's in that case, there are no more raising signs. Thank you so much for the wonderful lecture as always. Very good learning from you. and a wonderful question answer session, sir. Thank you so much.
Good seeing everyone. Take care. Bye.
One question, sir. Just a minute. One question has come. This is from Dr. Alpesh Kapadia. What is the futuristic role of NGS-based MRD in myeloma?
Right. So we have currently available, right? That's only FDA approved test right now is the next generation sequencing based testing by Adaptive, the clonoSEQ test. So yeah, we can look at the VDJ recombinant region and identify the clone. We need that to identify the clone at baseline and then look at it future. But I think in the future, what is likely to happen is we're going to do a singular targeted panel of sequencing at greater depth that will give us all the high risk abnormalities and also the VDJ base signature that we can then use for subsequent analysis.
Thank you so much, sir. Thanks a lot. Thank you.